Good afternoon, everyone. So today we will discuss about management of cirrhosis. Silence, please. So this is the natural history of any liver disease. So various etiology like chronic viral hepatitis, alcohol, non-alcoholic steatohepatitis, these are all causing chronic liver disease. And as as fibrosis increases, so then there will be development of cirrhosis of the liver. So cirrhosis is having two stages. One is the compensated stage, second one is the decompensated stage. So when will you say decompensated stage? When there is development of variceal hemorrhage, worsening ascites and encephalopathy. So once in cirrhosis these three conditions develop, so you will say patient has developed decompensated cirrhosis, and ultimately patient may develop hepatocellular carcinoma because cirrhosis is a precancerous condition. So either patient may develop SCC from the compensated cirrhosis or decompensated cirrhosis, or patient may die due to cirrhosis until unless he receive liver transplant. Okay. So this is the natural history. Chronic hepatitis leading to cirrhosis, initially compensated, later on decompensated, SCC, and finally death. So this is the definition of cirrhosis that we have discussed yesterday also. So cirrhosis is a consequence of irreversible liver injury followed by replacement of liver tissue by fibrous scar tissue as well as formation of regenerative nodules. So what it will cause? It will cause completely change in the architecture of the liver. Okay, so what will happen? There will be progressive loss of liver function. Okay. So these are various manifestation of cirrhosis of the liver. So few are due to liver cell failure and other are due to portal hypertension. Okay. So if we go from head to toe, so patient may have hepatic coma, this is due to hepatic encephalopathy, then he may develop fetor hepaticus. Why fetor hepaticus occurs? This is due to presence of what in breath? Which substance? This is due to presence of methyl mercaptan in the breath. Methyl mercaptan is produced by the protein metabolism. So in normal person it is metabolized by the liver, while in case of cirrhosis of liver it will circulate in the body and will excrete through breath. Then spider nevi, these are dilated arterioles over neck or upper chest. Then patient may have few manifestations due to hyperestrogenemia. These manifestations are gynecomastia, loss of axillary and pubic hair, testicular atrophy. These are all manifestations due to increased estrogen level in the blood. Then patient may have jaundice, ascites, bleeding tendency, anemia and ankle edema. And these manifestations are due to liver cell failure. Few manifestations will be due to portal hypertension. Why portal hypertension occurs in cirrhosis of liver? Why there is development of portal hypertension in cirrhosis of liver? Cirrhosis of liver is because of increasing fibrosis, there is complete change in the architecture of the liver. Okay, so that sinusoidal anatomy has completely changed. So now portal vein is not able to drain blood completely in the liver. So what will cause? It will cause back pressure changes. So there will be more blood in the portal vein. Similarly, so now how blood will reach to the systemic circulation? And now this large amount of blood need to be in the systemic circulation. So how it will reach? how it will reach SVC, IVC. Shunts, है ना? So there will be opening of few shunts. These are called portocaval anastomosis. Okay, so due to back pressure changes, there will be opening of the shunts. So there will be various collaterals through the systemic veins. So what are the sites of portocaval anastomosis? First one is the lower end of the esophagus, lower end of esophagus and upper part of the stomach. So that is the first site. Second site is rectal, है ना, rectal and anal canal. That second site. Third site is around umbilicus. Okay, so these three manifestation you can see. There are few sites which are not visible, like there are total 7 sites of portocaval anastomosis. So 3 are these, and fourth one is the bare area of the liver, and then retroperitoneal area, and then lower end of the spleen area. Okay, so these areas are not visible. So due to portal hypertension, first patient will have dilated veins over the lower end of the esophagus and upper part of the stomach. So these are called esophageal varices or fundal varices. So how patient can present? Now these dilated veins are there in the lumen, so they may rupture. So it will manifest as either hematemesis or melena. Okay, because of rupture of the esophageal vein, it will cause blood in the esophagus. Okay. Then there can be gastropathy because of dilated vein in the stomach. Okay. What is meaning of melena? What is melena? Now, if you don't know simple terms, then what is the purpose of then lecture? And this is a very basic term. Last one, corner, stand up. Stand up. You, last. Yes. What is melena? Black stool due to chalo, next to you. Next to you. You sit down. Next. Next one, second last row, corner. Describe what is melena. Due to bleeding from which side of the gut? So why black color appears? This is due to when blood come in contact with the gastric juices, pancreatic juices, bacteria, so it causes partial digestion of the blood. Okay, sit down. So that causes melena. So either esophageal varices will present as a either hematemesis or melena. Now due to back pressure, there will be enlarged spleen. So patient will have splenomegaly. Then there will be dilated abdominal vein. These are called caput medusae. And patient may develop ascites due to portal hypertension, and patient may develop rectal varices or hemorrhoid due to portal hypertension. So these are manifestation of portal hypertension, and these are manifestation of liver cell failure. Now, why we want to treat the cirrhosis of the patient? We know cirrhosis is an irreversible condition, but still we want to slow the progression of the disease. Okay. then preventing the superimposed insult of the liver, like in case of chronic viral hepatitis. So, we will treat the viral hepatitis because we do not want further damage to the liver. Similarly, in alcoholic liver disease, we want alcohol should not do further damage to the liver. Then once patient develop complication of liver, then we have to treat these complications like portal hypertension, ascites, encephalopathy, and determine the appropriateness and optimal timing for liver transplantation, because that is the final treatment of liver cirrhosis. So, there is no specific drug for cirrhosis of liver. Now, we have to manage the symptom and complication of advanced liver disease. So, we can divide the management of cirrhosis of liver into 4 headings. One is the general management, then specific treatment depending on etiology of the cirrhosis, then treatment of complications, and finally liver transplantation. So, general, we have to provide good nutrition, because these are most of the time these patients are malnourished. So, good nutrition, low salt diet, alcohol abstinence, avoid NSAID, because NSAID can precipitate GI bleed. Then avoid sedative and opiate, because this can precipitate hepatic encephalopathy. Then cholestyramine for pruritus, and avoid other hepatotoxic drug to prevent further damage to the liver. Then specific treatment, so like in alcoholic liver cirrhosis, we will advise complete abstinence from the alcohol, nutritional support, and in case of severe alcoholic hepatitis, if DH score is more than 32, then we can give prednisolone. In case of post-viral cirrhosis, if etiology is hepatitis B, then we can give tenofovir or entecavir. In case of hep C, we can give neuro and oral drugs for hep C, that is duration is 6 months, while in case of hepatitis B, we will give treatment for lifelong. And then if both co-infections are there, B and C, then we have to treat the dominant viral infection first. So, most of the time hepatitis C is dominant viral infection. And in case of drug induced cirrhosis, these are various drugs which can cause liver cirrhosis like methotrexate, methyl dopa, isoniazid. So, we have to stop these drugs and give symptomatic treatment. Then in case of primary biliary cholangitis, UDCA, ursodeoxycholic acid, dose is 10 to 15 milligram per kg, that is given, and we can give few immunosuppressant drug also like azathioprine, colchicine, methotrexate, cyclosporin. These patients will have fat malabsorption. Okay, so to prevent steatorrhea, we have to limit fat intake, and we have to give monthly injection of vitamin K, because these patients will have deficiency of fat soluble vitamin. In case of non-alcoholic steatohepatitis, we have discussed in the previous lecture that we have to control weight, diabetes, hyperlipidemia, and we can give, if patient is diabetic, then we can give metformin, pioglitazone. If patient is having dyslipidemia, then we can give saroglitazole or atorvastatin. In case of hemochromatosis, what is hemochromatosis? This is condition of iron overload. So, here we have to advise weekly venous action. We have to maintain the hematocrit less than 45. Okay. So, weekly venous action can be advised. Then chelation therapy. So, this desproxamine binds with the iron. So, we can give chelation therapy, and this iron deposition also occur in other organs like pancreas, heart. So, patient may have diabetes or congestive heart failure. What is the term used for this type of diabetes? This is called bronch diabetes. Bronch diabetes. Okay. So, we have to treat diabetes and congestive heart failure. Then Wilson's disease. What is Wilson's disease? This is the copper overload condition. So, here we have to give copper chelating agent. So, penicillamine or triamtine. We can give. What is the role of zinc in Wilson's disease? Zinc compete with iron, copper for absorption in the gut. Okay, so if we give the copper, zinc along with diet, so copper is whatever present in the diet that will not be absorbed. Okay, so that zinc will not cause, will cause further, it should decrease the absorption of the copper. Then these Wilson's disease patient may have neurological manifestation also. So in those cases we can give dimercaprol or tetrathiomolabdate. And finally liver transplantation is advised. And in case of hepatic outflow tract obstruction, most of the time these patients are having hypercoagulable state. So we have to control that underlying condition, and we have to advise anticoagulant therapy like heparin or warfarin, and sometimes percutaneous balloon angioplasty may be advised, and finally liver transplantation. So these are specific treatment depending on the etiology. Now third one is the management of complications. So what are important complications of cirrhosis of liver? First one is the portal hypertension. It can lead to ascites, can lead to bleeding esophageal varices. Patient may have coagulation defect, portosystemic encephalopathy with hepatic coma, hepatorenal syndrome, SBP, and hepatopulmonary syndrome. So we will discuss one by one. So how portal vein forms? When superior mesenteric vein joins with the splenic vein. Okay. While inferior mesenteric vein drains into the splenic vein. So portal vein forms by the joining of superior mesenteric vein and splenic vein. So in cirrhosis there is defect at the sinusoidal level. Okay. So when there is fibrosis in the sinusoid, so what will happen? This portal vein is not able to drain blood into the liver. So there will be pooling of the blood in these veins. Okay. So this is called portal hypertension. So what are the manifestation of portal hypertension? First one is the esophageal varices. Second one is the ascites. Why ascites occurs in portal hypertension? So okay. So in case of portal hypertension, now large amount of blood is present in the splenic circulation. So there will be less blood in the systemic circulation, more blood will be in the splenic circulation. Okay. So kidney will sense this condition as a hypovolemic condition. So what is the response of kidney to hypovolemia? Suppose somebody has blood loss, acute gastroenteritis, severe vomiting. So what is the response of kidney? Kidney will try to conserve more water and sodium. So there will be increased activation of RAS system. So there will be more angiotensin, more renin secretion. Okay. So kidney will conserve more water and more sodium. So it will lead to edema and development of ascites. So because of activation of RAS system, one mechanism. Other mechanism, now here liver is congested. So there will be some oozing of lymph around through liver. Okay. Third mechanism, there is hypoalbuminemia. So plasma oncotic pressure has decreased. So that will cause more collection of the fluid in the third space. Okay. So these are 3-4 mechanisms causing ascites. Sometimes that ascites may be infected. So that may lead, that condition is called spontaneous bacterial peritonitis, and then development of hepatic encephalopathy. So whenever there is presence of esophageal varices, that indicates patient is having portal hypertension. And now this is the risk for bleeding. Anytime patient may develop severe hematomesis, he may develop hypovolemic shock. So that's why all cirrhosis should be screened for esophageal varices by upper GI endoscopy. If these varices are less than 5 millimeter in size, we will say the patient is having small varices. If these are more than 5 millimeter, we will say large varices. this hepatic venous pressure gradient. Okay. This is the ideal way of measuring portal pressure. So, in this one catheter is passed through the jugular vein, and at the sinusoid level we measure the pressure. So, this is normally less than 5 millimeter. Okay. Normal hepatic venous pressure gradient is less than 5. When it is more than 5, then we will say patient is having portal hypertension. Okay. So, what should be the normal hepatic venous pressure gradient? It should be less than 5 millimeter. Now, this is the normal lumen. Here there is no varices. In this you can see few bluish spots are there. These are small varices, and here can you appreciate these are large esophageal varices. Okay. So, patient may develop varices. Their chance of progression is 7 to 8% per year. So, now what will you do? Suppose you are doing variceal surveillance. So, if there is no varices, then you will not advise beta blocker, you will advise repeat endoscopy every 3 years. Okay. If patient is having small varices, okay, so here you will advise non-selective beta blocker prophylaxis. Okay. What are non-selective beta blocker? Propranolol. Here we can use either propranolol, nadolol or carvedilol. Okay, these three types of beta blocker are used. What is the role of beta blocker in portal hypertension? How it acts? It causes splanchnic vasoconstriction. Okay, so it decreases the size of varices because of vasoconstriction. Okay, if patient is having medium or large varices, okay, then we have to advise beta blocker, and along with ligation. We have to ligate these large vessels. So, cirrhosis with no esophageal varices, there is no need to give beta blocker. If patient is having small varices, then we have to give beta blocker. So, what is the starting dose of beta blocker? Propranolol, it is 40 milligram per day. And how will you titrate the dose of beta blocker? What is the side effect of beta blocker? Especially these non-selective beta blocker, it can cause, important one is bradycardia. Okay, so we will monitor heart rate while giving beta blocker, and our target heart rate is around 60. So, we will every 3 to 4 days we will increase the dose of beta blocker till we achieve the heart rate around 60. Okay, so we can go up to 160, 200 milligram per day. Suppose patient is having large esophageal varices. At present there is no bleeding. Still we have to ligate these vessels. So, we can do endoscopic variceal ligation, and we have to repeat the endoscopy every 2 weeks till patient achieves complete obliteration. And here again we have to give lifelong beta blocker prophylaxis. And we have to achieve the hepatic venous pressure gradient less than 5. Now, suppose patient coming with bleeding esophageal varices. Patient came with massive hematemesis. Okay. So, now what will you do? In case of emergency, you have to give vasoconstrictor agent like somatostatin. Okay. So, somatostatin, octreotide, terlipressin. Octreotide is the somatostatin analog, while terlipressin is long acting analog of vasopressin. Okay. So, what is dose of terlipressin? This is most commonly used agent, terlipressin. What is dose of terlipressin? It is 2 mg every 6 hourly till bleeding stop, and then 1 mg 6 hourly for next 24 hours. Okay. So, patient coming with bleeding, first you will give terlipressin 2 milligram. Then depending on the, if patient is having anemia, then you have to give blood. Patient is having increased prothrombin time, so you will give fresh frozen plasma. If patient is having thrombocytopenia, then you will give platelets. Then prophylactic antibiotics, so that patient should not develop SBP. Then balloon tamponade, these three things we will discuss in next slide. And then long term prophylaxis by non-selective beta blocker. Suppose patient is having some contraindication for beta blocker. What are the contraindication of giving beta blocker? What are the contraindication of using beta blocker? Asthma. Okay, very good. So, because these non-selective beta blocker can cause bronchospasm. Okay. So, in asthma cases we can use carvedilol because this is also having alpha action. So, this will cause bronchodilation. Okay. So, in case of COPD asthma patient we can use carvedilol. What are the other contraindication apart from COPD asthma? Suppose somebody is having already heart block, then beta blocker are contraindicated. So, in those cases we can use nitroglycerin, okay, for this prophylaxis of esophageal varices. Now, suppose patient is coming with bleeding in a place where facility of endoscopy is not available. Suppose patient is coming any PSC, CSC with bleeding. So, you can place this tube. This is Chang-Stacken Blackmore tube. Okay. Have you seen Ryle's tube? That is having only single lumen. Here this is just like Ryle's tube, but it is having 3 lumen, 1, 2, 3. Okay. So, this middle one, middle lumen, this is for the aspiration of the gastric content. Okay. Now, second lumen, this is for inflating gastric balloon. Through this will connect the syringe and will inflate the air. So, this will cause this balloon. So, this balloon will compress the whatever varices are there around the gastroesophageal junction. Okay. And third balloon is esophageal balloon. So, this will compress the esophageal varices. Okay. So, this will temporarily stop the bleeding, so that you get the time to transport the patient to higher center. Okay. So, this is balloon tamponade by Chang-Stacken Blackmore tube. Okay. Why we can't keep it for long time? Why this is short term measure only? Because now this is causing continuous pressure over this area. So, after few hours patient will develop necrosis of that area. Okay. So, this is just temporary measure, just for transportation of the patient to higher center, temporary measure. Now, second one is this is the definitive measure. You will transport the patient to higher center where facility of endoscopy is available, and through endoscopy you can ligate these vessels from the base. Okay. So, vessel that is bleeding you can ligate this vessel. So, that is called endoscopic variceal ligation. Okay. You can also inject some sclerosing agent that causes hardening of the lumen of the vein. So, either you can do ligation of these vein or you can inject some sclerosing agent in this. Okay. Now, suppose still bleeding is not controlled. Okay. Now, how will you decrease the portal pressure? This is TRIPS, transjugular intrahepatic portosystemic shunt. Okay. So, in this this is portal vein, these are hepatic vein. Okay. So, what we have passed one catheter through jugular vein from the hepatic vein up to the portal vein, and we will place one stent over this catheter. So, now what this is causing? There is one shunt between portal vein and hepatic vein or IVC. This one. So, what this shunt is causing? This shunt. What is the role of this shunt? This is called TRIPS. So, what is this shunt is doing? So, this is draining blood directly from portal vein to hepatic vein. So, this will completely decrease the pressure in the portal system. So, pressure in the varices will also decrease and bleeding will stop. But what is the disadvantage of this shunt? Okay. And also this has completely bypassed the function of the liver, like metabolic function, detoxification function. So, now whatever these toxins, toxic metabolites are present coming through the gut, these are directly reaching to the systemic circulation. So, now patient will develop hepatic encephalopathy because ammonia will not be neutralized in the liver. So, there are high chance of development of hepatic encephalopathy. What can be other disadvantage? One of the another function of the liver is the storage. Liver, whatever excess nutrient are there in the blood that are stored in the liver, but now these are reaching to the systemic circulation and through kidneys it will be filtered out in the urine. So, patient will develop malnutrition. Okay. So, that is why this is also not a definitive treatment. This is bridge to liver transplant. Okay, so that you get some time for liver transplantation. So, TIPS is a bridge to liver transplantation. Now, next complication is ascites. Now, ascites, how will you diagnose ascites? One is clinically, second by the imaging. Now, you have to confirm whether this ascites is due to portal hypertension or not. Sometimes these patients may develop tuberculosis of the abdomen, these patients may develop malignancy. So, that ascites may be due to other causes also. So, how will you? So, you will calculate serum ascites albumin gradient. Okay. So, you will measure the serum albumin level, you will measure ascitic albumin level and you will calculate this ratio. So, if that SAG is more than 1.1, that suggests etiology portal hypertension. Okay. Serum ascites albumin gradient. Okay. Serum albumin minus ascites albumin. If this ratio is more than 1.1, okay, we will say ratio, but this is minus, serum albumin minus ascites albumin. So, if this is more than 1.1, that suggests etiology is portal hypertension. Okay. Then you will measure the fluid cell count, you will send for culture whether to know whether patient is having SBP. Now, what is the treatment of ascites? So, now we know that patient is having increased sodium because of RAS activation. So, we have to restrict the sodium through diet. So, we have to give less than 2 gram per day of sodium. Okay. So, how will you calculate this 2 gram sodium? 1 tablespoon salt contain 2 gram sodium. Okay. So, in whole day patient has to take सिर्फ 1 चम्मच नमक लेना है. Okay, that will equal to 2 gram of sodium. So, in whole day patient has to consume 1 tablespoon of salt only. Then you have to give diuretic. Okay. So, why spironolactone is drug of choice? Because this act against this aldosterone antagonist. We know there is RAS activation in cirrhosis liver. So, we will give spironolactone is drug of choice for using as diuretic, but this is weak diuretic. So, we will not achieve much diuresis by giving spironolactone. So, that is why we have to combine this furosemide. Furosemide is a loop diuretic, that is potent diuretic. Okay. So, for management of ascites we have to give furosemide with spironolactone along with low sodium diet. And how will you titrate the dose of diuretic? You have to achieve the weight loss. So, at least patient should have half to 1 kg per day weight loss. Accordingly, we will titrate the dose of diuretic. What is dose of spironolactone? What is starting dose of spironolactone? Starting dose of furosemide is 40 milligram, spironolactone is 50 to 100 milligram. Okay, so we will start in the dose of 40 milligram furosemide, 100 milligram spironolactone, and you will check the goal whether you are achieving this goal or not. Half to 1 kg weight loss of the patient. Okay, because patient is having peripheral edema, ascites, so after diuresis his weight will decrease. Okay, so you have to target this much goal, okay, at least 1 kg weight loss should be there, and you can go up to 400 to 160 milligram. Maximum dose of spironolactone is 400 milligram and maximum dose of furosemide is 160 milligram. But majority of the time patient we cannot go up to this much because patient will have side effects. What are the side effects of diuretics? Spironolactone and furosemide. Side effect of spironolactone, this is potassium sparing diuretic. So, patient may develop hyperkalemia. So, we have to monitor potassium. What is side effect of furosemide? It can cause hyponatremia, sodium loss. So, it can cause hyponatremia, hypokalemia, hypocalcemia. Okay. So, these electrolytes we have to monitor. What is one more important side effect of spironolactone is this is steroidal type drug. So, it can cause gynecomastia. One of the side effects of spironolactone is gynecomastia. Now, what is refractory ascites? So, even after using maximum dose of diuretic or maximum tolerated dose of diuretic, suppose you have given up to this much high dose of diuretic, still ascites is not responding, not resolving. So, that is called refractory ascites. Okay. So, what is treatment of refractory ascites? Either you can go large volume paracentesis. Paracentesis means ascitic tapping. So, you will remove large amount of ascitic fluid. Now, this large amount of fluid also contains protein, okay, and already patient is protein deficient. So, that is why you have to supplement albumin. So, you have to give 20% albumin. Now, what albumin will cause? How albumin will help in cirrhosis of liver? It will increase the plasma oncotic pressure, so that there should not be rapid refilling of the ascites. Okay. So, treatment of refractory ascites is large volume paracentesis along with albumin injection. Okay. Or we can go for oral midodrine. This is alpha agonist drug. It causes vasoconstriction in the splenic circulation, or we can advise TRIPS, and ultimately liver transplantation is advised in case of refractory ascites. Now, SBP, spontaneous bacterial peritonitis. What is SBP? So, suppose a cirrhosis patient with ascites coming with fever, pain abdomen, leukocytosis, then you will suspect SBP. Okay. Important one, you have to rule out secondary peritonitis. Okay. So, what are there are various types of peritonitis. Primary means there is no underlying etiology. Secondary means somebody is suppose having some abscess in the abdomen that has ruptured, liver abscess has ruptured, splenic abscess has ruptured, somebody has ruptured appendix, ruptured gastric ulcer. So, that can also cause ascites. So, that is called secondary peritonitis. While primary peritonitis means there is no surgical cause, there is no perforation, no abscess, still patient has developed infection of the ascitic fluid. Okay. So, how that bacteria can reach then peritoneum? So, there may be some translocation of the bacteria. Now, you know gut is filled with the bacteria. So, sometimes there is migration of the bacteria from gut to peritoneum. So, that can cause peritonitis. So, how will you diagnose SBP? When ascitic fluid neutrophil count is more than 250. You have done the ascitic tapping, you have sent the fluid, you have sent for albumin estimation, you have sent for cell count. So, if that cell count is more than 250, it suggests patient is having SBP. These are various organisms which can cause SBP like E. coli, Klebsiella, Streptococcus pneumoniae, and drug of choice for SBP is cefotaxime. We can use either cephalosporin or beta-lactam antibiotic. So, cefotaxime 2 gram every 8 hourly for 5 days is drug of choice, and we have to give prophylactic antibiotic to prevent future recurrence of SBP. Now, there are other complications of cirrhosis like hepatorenal. Name itself suggests renal dysfunction due to liver cirrhosis. Then hydrothorax or pleural effusion, umbilical hernia, cellulitis. Okay. This is the mechanism of development of hepatorenal syndrome. Patient is having vasodilatation, so there is decreased effective arterial blood volume, and there is activation of various neurohumoral system. So, this will cause renal vasoconstriction and patient will develop hepatorenal syndrome. Okay. What is important here? Anatomy wise, kidney are normal. Only because of decreased blood supply to the kidneys, they are having dysfunction. Okay. So, this is called hepatorenal syndrome. Any query about this? You can ask any time if you are not getting anything, not understanding mechanism of any complication. So, how will you treat hepatorenal syndrome? Here we have to avoid the overuse of diuretics, because that will also cause hypovolemia, decreased blood supply to the kidneys. Then we can go for volume expansion by IV albumin. We can use terlipressin because that will cause vasoconstriction in the splenic circulation and increase blood supply to the other part of the body. So, we can go for terlipressin and ultimately liver transplant. This hepatopulmonary syndrome because of this AV shunting around the alveoli. So, name is hepatopulmonary. Patient develop hypoxia because of liver cirrhosis. And lastly, hepatocellular carcinoma. Okay. So, if lesions are small, then we can advise the surgery or we can go for ablation of these. So, percutaneous ethanol or acetic acid is injected in these hepatocellular carcinoma. Now, there are various scores are there. Now, how will you know whether patient is having severe disease or mild disease? So, one is the Child-Pugh score, second one is the MELD score. So, here there are 3 categories are there, Child-Pugh category A, B and C, and there are 5 parameters. One is the hepatic encephalopathy, ascites, bilirubin, albumin, prothrombin time or INR. So, based on these 5 parameters, you will calculate Child-Pugh score and accordingly you will grade him whether he is in category of A, B or C. And these MELD score we have discussed in previous lecture also, that we required value of bilirubin, INR or serum creatinine. Any question?